Hello, everyone, and welcome to today's webinar, The Quality Payment Program, Are You Ready to Succeed in 2019? My name is Amanda, and I'm the Marketing Manager here at AOTA, and I'm going to point out a few things about today's presentation. First, CE. You can earn 1 CE contact hour for each webinar attended during Member Appreciation Week. At the conclusion of the webinar, you will receive an email from AOTA Webcast containing a link to your CE certificate. However, you must stay on for the entire webinar until you view the pop-up screen that says the webinar is now over in order to receive your CE certificate. Next, questions. On the left side of your screen, you'll see an Ask a Question pod. This is for you to type in questions you may have for our presenters throughout the webinar. Questions will be answered towards the end of the webinar, and the presenters will do their best to answer as many questions as time allows. And last, resources. Additional resources for this webinar can be found in the Event Resources pod located below the Ask a Question pod. Simply click on the pull-down arrow to view the available resources and download. And with that, let me introduce today's presenter, Jeremy Furniss. Jeremy?
Hi, thanks, Amanda. And thank you, everybody, for joining us today. We've got a lot to talk about, so we're just going to dive right into the Quality Payment Program, Are You Ready to Succeed in 2019? First off, we have a few notes. One, the final rule for the Quality Payment Program, or QPP, has not been published to the Federal Register yet. We do have a display copy, but it has not actually been published in the Federal Register. So this information is based on an initial review, and more detailed information will be coming soon to aota.org, so keep your eyes out. And throughout the presentation, we will be talking about benchmarks that are required to score the QPP performance. I want to note that the 2019 benchmark files have not yet been published. We expect them any day now, but CMS is completing the data analysis that is needed to publish those. So when we reference benchmarks throughout the day, all of that information is estimated based on last year's information. I also wanted to point out the quality team. I'm lucky enough to present with you guys today, but we also have Sharmila Sandhu and Jennifer Bogenreef, who are instrumental in all of the work associated with not only QPP, but all of the quality efforts at AOTA. So our agenda for today, we're going to touch on some great news that can be found in the Medicare Physician Fee Schedule and Quality Payment Program Final Rule. We're going to look at QPP and MIPS specifically, which is the Merit-Based Incentive Payment System from 10,000 feet. Then we're going to hone in on, are we ready for QPP? Some questions to ask to make sure that we're on the right track. We'll review how you calculate your final score for QPP. Provide an example that hopefully kind of pulls everything together, and then take some time for questions and comments. So first of all, some great news. Functional limitation reporting is no longer required as of January 1st, 2019. So this is often affectionately referred to as the G codes for function, and they are finally going away. So as of January 1st, you will no longer need to submit G codes for functional limitation reporting to CMS. And also the therapy cap is gone. This is another huge success for the AOTA advocacy with regulatory affairs and federal affairs. The therapy cap is no longer. You do still have to use the KX modifier this year for claims over 2010. And starting in 2019, that amount increases to $2,040. There is still the possibility of manual medical review over $3,000 in billing. And a few notes on volume to value. So the healthcare system and many of the wellness aspects are shifting from a volume-based system to rewarding value. We really believe that OT can be a leader in the shift from volume to value. The OT frame of reference and the way that OT approaches clients in a collaborative manner and views holistic practice really is the gap that a lot of the healthcare and health systems are looking for. So we're really excited to promote OT being a leader here. All settings are seeing a greater emphasis on quality measures. These quality measures are the way that CMS and other payers are trying to capture and quantify that value. So it's not just Med B and outpatient, it's every single setting that OT works in. But in Med B and outpatient, the shift is being led by the quality payment program that we're going to talk about today. So just know that if you work in Med B and are under QPP, you are not alone. There are a lot of systems and a lot of changes throughout the entire health system that is moving us to be able to quantify our value. So let's take a look at the quality payment program from 10,000 feet. What are the big picture items related to QPP? First of all, who participates in QPP? This slide is actually taken from a quick start guide to MIPS that CMS has published, and we have links available at the end of the presentation where you can get more information on that. But all of these different clinicians are a part of QPP in 2019. And right there in the center, you'll see occupational therapists have been added. If you look on either side of us, some of our other rehabilitation and habilitation colleagues are there as well, but we're obviously focusing on OT's role today. So the quality payment program applies to Medicare Part B outpatient claims. It does not apply to Medicare Part B facility-based services by OTs yet, although CMS has been very clear that they are looking and trying to decide how to capture facility-based practice for therapists. So we may see that change in the near future. A quick litmus test on if it might or might not apply to you is to look and see, is the OT NPI provided on the bill to CMS? So if your OT NPI is required to bill CMS, then likely QPP applies to you. If it is not, then it may not. Another fact is January 1st, 2019 begins year 3 of that program. So it's year 3 of QPP, but it is the first year that occupational therapists are called eligible clinicians, and the first year that OTs are included in this role. I do want to point out ECs, that abbreviation for eligible clinicians. That's used throughout the presentation, so I just want to make sure that I highlight that. ECs is not an abbreviation that we use very often, but it is all the way throughout QPP, so it's a new one for us to get used to. There's a low volume threshold that determines eligibility, and we're going to get into details on that, but the take-home message on that is a small number of OTs are going to be mandated to participate in QPP. So a very small number will be actually required to participate. However, the exciting part is a very large number of OTs will have the opportunity to opt into QPP. Now, I know what you're thinking. Why would I opt in? And we're going to cover that. So hold on. Also, there are some considerations for small practices, which are 15 or fewer eligible clinicians. And AOTA's regulatory and quality groups have been advocating and following QPP for all 3 years of the program. So for the last 3 years, regulatory has been advocating on behalf of OT, anticipating OT would be included, to encourage the low volume threshold, to maintain a reasonable amount, and then also to maintain the considerations for small practices. So in QPP, there's 2 tracks. The first track that you see on the left here is the Merit-Based Incentive Payment System, or MIPS. The second track on the right is APNs, or Alternative Payment Models. So for today, we're going to focus on MIPS, and we're going to highlight most of our resources related to MIPS, primarily because as it is now, it is very hard for an individual clinician as an OT to get credit in APNs. This may change in the future, and we'll keep our eye on it. But we believe that most, if not all, OTs who are in QPP will be a part of the MIPS track. So we wanted to get this highlighted at the very beginning. So 2019 is going to be the easiest year for OTs to participate in MIPS. It's only going to get more challenging down the future. So whether you're considering participating or not, we're asking you to keep an open mind, because 2019 will be the easiest year to participate and the easiest year to avoid the negative penalty and possibly even get a bonus. So keep your open mind as we talk throughout this. So eligible clinicians may participate as individuals or groups. MIPS is based on performance in up to 4 categories. And based on your performance in those up to 4 categories, each EC has a final score between 0 to 100. So based on that final score of 0 to 100, the best performers can earn up to a 7% payment bonus in 2021. The worst performers can earn up to a 7% penalty to all payments in 2021. So it's actually feasible for two OTs billing the exact same CPT codes in 2021 to have a payment differential of up to 14%, which is pretty substantial. So it's really important that we're prepared and ready to participate to avoid the negative and then also earn some of that positive. I mentioned that there's 4 categories for MIPS. In 2019, OT is only going to have to compete in 2 of those 4 categories. So the 2 categories that OT is going to compete in are quality and improvement activities. We're not going to touch on cost or promoting interoperability. Those are the other 2 categories that may apply to OT in the future, but will not apply to OT this first year. So let's dig into each of these in a little more detail. First, quality. It's 85% of your total score for OT. It's a 12-month performance period, so it looks at January 2019 all the way through December 2019. You're required to report at least 6 measures, which is down from 9 measures that PQRS required in its last year. And at least one of those 6 must be an outcome measure, or if no outcomes are available, then at least one of those 6 must be a high priority measure. And this is scored based on performance compared to a benchmark. Remember at the beginning, I mentioned that the 2019 benchmarks are not out yet. So we're going to talk about benchmarks, but we'll also keep our eye on CMS publishing the 2019 benchmark. So to calculate quality, there's 60 points possible. So I kind of think about back to my university days. If quality was a test, it's worth 60 points. There's 60 points possible on that test, but it's 85% of my total grade for that term. So you get between 1 and 10 points for each measure. So if each measure is a question, the question's worth 10 points, 60 points possible, 85% of my total grade. You can submit quality in 3 different ways to CMS. The first is claims, and that's only for small practices. We'll talk more about small practices in the future. You can also submit them directly. That's typically done through a third party, like a registry, where they submit the information for your quality measures directly to CMS. And then the third opportunity is login and upload. And that is where you would probably download a file from your EHR or other electronic means, log into the CMS website, and then upload that file so that you pass along your quality performance information to CMS. The MIPS quality measures are going to look very familiar if you participated in PQRS. So this first screen looks at all of the MIPS quality measures that can be reported via claims. So the first column is your high priority. So remember, you have to have at least one high priority or outcome. The exclamation point there tells you if it's a high priority measure or not. That second column is a quality measure number, and that's the number you can use to look up lots of more detail about the quality measures. On the right, we have if the measure is included in the specialty list for physical therapy and occupational therapy. And then finally, on the far right-hand side, we have an indicator on if you can report that via claims, and keep in mind that's only for small practices. So the measures are BMI, documentation of current meds, pain, functional outcome, there's 2 falls measures, a clinical depression measure, elder maltreatment screen and follow-up, and then tobacco cessation. And I would also like to point out that if you look in the Event Resources tab on the left-hand side of the screen, you can download the OT MIPS measure list that is still in draft form, but you can download it and it provides a lot more detail on all of these measures. We're waiting for some feedback on the falls measures from CMS, so once we get that, we will finalize that and make it available via AOTA.org. The second list of measures are measures that cannot be reported by claims, whether you're a small practice or not. So they either have to be reported via direct methods, like through a registry, or via login and upload methods. And I really want to point out these first 4 measures that are dementia measures. And OT was involved in creating these measures with other organizations such as PCPI and the American Academy of Neurology. So there are 4 quality measures related to dementia. And then the measures at the bottom of the list are all the outcome measures that focus on therapeutic outcomes or PHOTO has created and maintains. So the other category that applies to OT is improvement activities. It's 15% of the final score. And instead of a 12-month period like quality, there's only a 90-day reporting period. So it's a much smaller, more manageable time frame for improvement activities. And the way that you report these to CMS is you have to attest that you've completed one of the CMS-approved activities directed at improving the care you provide or the outcomes that your clients achieve. So there's 40 points possible in improvement activities. So if we think back to our class, there's 40 points possible on the improvement activity test, and it's worth 15% of our final grade. And improvement activities can be submitted via 3 ways. 1, direct, 2, login and upload, that work just like we were talking about in quality. And then the third method is the method that we think most OTs and actually most clinicians will use, and it's login and attest. So you log into the CMS website and you attest that you completed the activity. Now, there are lots of different improvement activities that have been approved by CMS. We went through and selected 4 just as an example. There's lots more that relate directly to OT, and you can use any of the activities that have been approved. But these 4 provide a decent example for conversation. The first one is depression screening and follow-up plan, which fits really nicely into the social and behavioral aspects of the OT scope of practice and frames of reference. There's also the opportunity to implement a fall screening and assessment program, which fits really nicely in with OT again. And then this one I really like. The third one is exciting. Engage patients, family, and caregivers in developing a plan of care. That one has definitely got OT written all over it. And the fourth one that we've listed here is employing patient-reported outcome tools and corresponding collection of patient-reported outcome data. Now, if you look on the right-hand side, you'll see that there's 2 different weights that each of these have. One is medium for the first 3, and then the last one is a high-weighted activity. So high-weighted activities are worth more points. Medium-weighted activities are worth less points. So we said that there's 4 categories to MIPS, and OT is only reporting 2 of those 4 for the first year. So we wanted to provide you the breakdown. For the other clinicians who are reporting all 4, you can look at that top line and see the breakdown by percentage. If you look at the second line, that's for OT this year, where 85% is quality and 15% is improvement activities. So earlier I mentioned that you could report via group you could report as a group or as an individual. So we wanted to touch on that briefly. First, you may report as an individual as a single clinician, and that's whether you work with other people or if you're a solo practitioner. You can also report as a group, which is 2 or more clinicians in the same practice. And then CMS has also created this thing called a virtual group, where small groups or individual clinicians can virtually group together with other clinicians from around the country and develop a virtual group where they report together and they receive the payment adjustment together. So keep in mind that groups and virtual regroups report aggregate data, so it's not necessarily all individualized. And then all clinicians in the group receive the same payment adjustment, either up or down. So now let's move into, are we ready? The big questions. So we sat down after reviewing this rule and said, what are the big questions that we would be asking right now to determine if we're ready for MIPS or not? So this hopefully gets the ball rolling, and we think that these are the questions that are really important that we would encourage you to start thinking about over the weekend and definitely start tackling on Monday. We put together a bit of a decision tree here, and we're going to use this decision tree as we talk about each of these questions. So the first burning question on most people's minds is, do I have to participate in MIPS? Am I mandated? CMS has actually created a fantastic tool, and they say check your participation status. So CMS provides this tool at qpp.cms.gov. You'll hear that website a lot today. It's actually one of the best websites I think that CMS has ever built, very user-friendly. So you'll look for this box that you see here, enter your NPI number, click check years, and it will tell you if CMS believes that you are mandated to participate, have the opportunity to opt in, or are excluded from the program altogether. Unfortunately, this tool does not have 2019 data right now, but it will very soon. So the final rule is hot off the presses, and we're actually beating CMS at some of the information. So keep an eye out on qpp.cms.gov and check that. There are several factors that determine whether you participate or not. The biggest factor is the low volume threshold. So the LVT criteria is reviewed every year, and it has in fact changed every single year. So this is year 3 of the program, and there have been 3 different levels of low volume threshold. MedPAC and some of the other groups, including some members of Congress, are recommending that CMS eliminate the low volume threshold altogether. And CMS has made it very clear that they are keeping an eye on the low volume threshold. Now, I point that out because if you're excluded this year, it does not necessarily mean that you will be excluded in the future. So we'll want to keep a close eye on that. CMS uses 2 determination periods for the low volume threshold. The first is October 1st of 2017 through September 30th of 2018. That ended just a few weeks ago. The second period is October 1st of 2018 through September of 2019. So these 2 different participation periods or determination periods are used consecutively to decide a lot of different things, one being low volume threshold. CMS does clearly state that if you're exempt in the first period, so if during the first period you're exempt, they will not add you or make you mandated based on your performance in the second period. However, if you're mandated in the first period, and then during the second period, your volume drops dramatically and you're no longer mandated, then they will let you out of the program. So the second period is not used to add anyone, only to determine special status. So the big question is, do I have to participate in QPP? Do you meet all 3 of the low volume threshold criteria below? So the first one is, in that determination period, did you see more than 200 Medicare beneficiaries? Did you bill more than $90,000 in allowable charges? And third, did you bill more than 200 covered services? So we have a couple of examples here. Practitioner A at the top billed $7,500 in allowable charges, provided services to 35 beneficiaries, and provided 175 covered services. So that person did not meet any of the 3 and is not required to participate. Practitioner B did not meet allowed charges, did not meet the number of beneficiaries, but did provide 1,200 services. So they did exceed the number of services. So they exceeded one of the 3. They also do not have to participate, because to be mandated to participate, you have to meet all 3 of those criteria. So do I have to participate in MIPS? No. The next big question is, can I opt in? So again, we return to the low volume threshold. If you meet at least 1, but not all 3, then you can opt in. So let's take a look at our examples. Practitioner A did not meet any of the 3, so they are exempt and cannot opt in. Practitioner B met one of the 3, provided over 200 services, so they are exempt, but they may opt in. So we're going to go with practitioner B here and say, yes, I can opt in. So then the big question, do I opt in? A lot of people would say, well, why would I? Why would I opt into this new program that has extra requirements when I don't have to, when I'm not mandated? Well, there's a couple of reasons. One, Part B fee schedule updates are going away. So this year there's a very, very small update, a very small increase in the Part B, but that increase is going to continually get smaller over the next few years until it goes away completely. So QPP will be the only way to increase Med B reimbursement. Also, changes in the low volume threshold will likely mandate that more OTs participate in the future. So if you have the opportunity to opt in this year, then it's also possible that you may be mandated either next year or in 2 or 3 years. So this is a great opportunity to take advantage of the easiest year to participate, gain experience, and even possibly gain bonus payments by participating in QPP. CMS has also been very clear in the final rule that they will include more of the categories for OT in the future years. We've talked about OT only has to report 2 of the 4. CMS is planning on including OT in 3 or 4 of the 4 in the future. So this is another opportunity to gain experience and practice before the program gets more complicated. So we also racked our brains on why would I not opt in? Why would I choose to not if I can? The first one is I'm certain that I will no longer bill Medicare Part B after January of 2020. If I know for sure I'm not going to be billing Part B, then maybe I don't opt in. The second, I would rather maintain my current reimbursement rate for the foreseeable future. So with that Part B payment update going to 0, in 10 years, the Part B payment rates could be exactly what they are today, unless you're participating in QPP. So that if you're very, very comfortable with that and that feels good for the foreseeable future of your practice, then maybe you wouldn't opt in. And the third one is, I know I would perform poorly in quality measures, and I need at least 1 more year to prepare to participate. So maybe you don't opt in this year, but you plan on opting in future years, and you're going to work on this year on getting everything together. That could be possible as well. So if you log into qpp.cms.gov, you can check your participation status, and then you also have the opportunity to decide which of these three categories you're in. So if you see a window like this, you're required to participate, that means you don't have a choice. You absolutely have to. You may also see a window like this that says you can voluntarily report, or you can choose not to participate at all. So that is someone who is exempt and cannot opt in. They don't have the opportunity to opt in, but they can still voluntarily report data. And then we think most OTs are going to see this screen where you have the option to opt in, to voluntarily report, or to not participate. And I do want to point out that once you log into the website and select one of these options, that selection is irrevocable for 2019. So put some real thought into it and really consider the rest of what we're going to talk about today before going in and selecting it, because once you've selected it, you cannot change it in 2019. You have to wait until the 2020 performance year to make any changes. So the next big question that we would ask, do I qualify as a small practice? A small practice is a practice with 15 or fewer eligible clinicians. It uses that exact same determination period as the low volume threshold. So CMS understands that small practices have unique challenges. Larger practices have more revenue, have the opportunity to invest in more advanced technology, and likely even have more non-clinical staff to help them through this process. So CMS provides small practices with a couple of bonuses and extra considerations with the understanding that they may not have the same advantages that larger practices do. So the first one is small practices can report quality measures via claims. We talked about that earlier. If you're not a small practice, that is not an option. Also, small practices get to add bonus points in their quality category. We'll talk about what that looks like too. And then quality measures that do not meet data completeness requirements. So if you don't meet all the requirements for CMS, if you're a small practice, you receive 3 points. If you're not a small practice, you only receive 1. So CMS triples the points there. And then finally, you get to receive more points, actually double points, for improvement activities if you're a small practice. So identifying yourself as a small practice is a really critical component to understand which of these pathways you may be in. We also believe that most OT practices would be small practices with less than 15. So we're going to continue down that track. So you do not have to if you do not have to participate and you choose to opt in and you are a small practice, then the next step is to choose 1 high priority or 2 medium priority improvement activities. And small practices, practices in rural areas, and practices in health professional shortage areas get double points for their improvement activities. So that means they receive their full credit on that IA test if they use 1 high-weighted activity or 2 medium-weighted activities. They can also receive half IA credit if they just complete 1 medium-weighted activity. Next, if we're a small practice, we get to add 6 points to our quality numerator. So keep in mind, we talked about quality has 60 points possible. You get between 1 and 10 points per measure, up to 6 measures. And then whatever that score is, if you're a small practice, you get to add 6 points to that. So that's an extra bonus and an extra incentive to understand that small practices may have some challenges competing with larger practices. And then finally, you'll want to choose a minimum of 6 quality measures to report. Right now, I would like to point out on the left-hand side, you can download the detailed list of quality measures under resources. We talked about that earlier, but if you haven't done so yet, I would definitely encourage you to do that. You must report at least 6, but the cool thing is if you report more than 6, then CMS is going to take the top 6 scoring measures. So reporting more than 6 gives you a little bit of an advantage as well. So it's also possible that you're not a small practice. There are some OT practices that will not meet that 15 or fewer ECs. So let's talk about what would be different for those guys. First, you'll have to select 40 points of improvement activities. So you get 10 points for medium or 20 points for high. So you could do any combination. 2 high weighted would get you all 40 points, 4 medium weighted, or a combination thereof. You also only receive 1 point for quality measures that do not meet data completeness, and you cannot report via claims. And then the last category of OT practices that we see are those who cannot or do not opt in. And if you cannot or do not, we would really, really encourage you to practice with voluntary reporting. So this gives you an option to practice reporting your quality measures. You get feedback from CMS. You get no loss if you're not successful. So if you do really, really poorly, there's no loss for you. Also, if you do really, really great, there's no gain for you. But there's an excellent opportunity to prepare for the future. So if you would log into qpp.cms.gov, check your status, and then we have it highlighted right here, voluntary reporting. The participant is not required to participate in CY 2019, but can volunteer to report, and they will not receive a MIPS payment adjustment. So you can select that and get practice this year without risking a negative payment adjustment. So calculating the final score, we talked about after MIPS is over, you get a score of 0 to 100, and that determines your payment adjustment. We're not going to spend a ton of time because we're going to pull this together with an evaluation, an example at the end. But if you're calculating quality, we've talked about this, 10 points per measure. You must meet 60% for data completeness, and that means 60% of the beneficiaries that apply to that measure have that measure submitted for them. So you have to have at least 60% of the people who apply to the measure that are measured. You also must have at least 20 beneficiaries for each measure. And that's just to make sure that the averages are reasonably reliable. And then there's also some bonus points that you can see there at the bottom. You can download these slides and go through that in more detail. We wanted to provide a slide on data completeness because we think that that is an important thing to understand going into the process. Basically, each measure requires 60%, and you can download and look at that in more detail. So for calculating improvement activities, again, 40 points possible. It's over a 90-day period, 10 points for medium, 20 points for high, and double points for small and rural practices. So once you get this entire total, this is the end result. So your total score can range from 0 to 100. If you look right there in the middle in the purple, if you get 30 points or higher out of the 100, then you get a neutral payment adjustment. So it only takes 30 points to remain flat. If you get between 30 points and 80 points, then you get a positive payment adjustment in 2021. The bar is not set super high. If you're able to get over 80 points, then not only do you get a positive adjustment, but Congress has set aside a budget where you're able to get an exceptional performance bonus. So you get the added bonus from MIPS, but then you also get even more that Congress has set aside for the first few years of MIPS to encourage practitioners to really excel at the program. I do want to point out at the bottom, if you get 7.5 points or less, then you must take the full negative 7%. If you do anything at all in QPP, it is very difficult to get 7 points. So Remember, improvement activities are 15%. So even if you just do improvement activities, you could get 15 points out of that. So doing nothing gets you the -7, and then 30 points gets you neutral, and then over 80 points gets you the superstar extra bonuses. So here is the total score calculation. We're going to go through this in the example, but we wanted it on one slide so that you could review that after the presentation. So now let's talk through the example. We're going to go back through the decision tree. An OT owns a private practice. She bills Medicare Part B, and she's a solo practitioner. So from October 2017 to September 2018, she bills about $120,000 in allowable charges. She treats 126 beneficiaries, and she bills 3,428 covered services. So if we're asking the question, do I have to participate in MIPS? She meets 2 of the 3 low volume threshold criteria. She does not meet number 2, which is treats more than 200 beneficiaries. So no, she does not have to participate. If we look at can I opt in, again, we look back at the low volume threshold criteria, and we just talked about she met 2 of the 3. So yes, she can opt in because she meets 1 or more. So then the question comes up, do I opt in? So she considers the upside, reviews her current practice, and she decides to opt in. So she logs into qpp.cms.gov, sees the options below, and selects opt in. Next question, do I qualify as a small practice? She works as a solo clinician, so she's the only clinician in her practice, which is definitely less than 15. So yes, she qualifies as a small practice. So then she looks at improvement activities. She goes to the website, she reviews all of the improvement activities, and she decides to implement the Promise 29, which is a global patient-reported outcome measure that looks at function, social, behavioral, and lots of different areas. Promise is often included in EHR packages. So she's going to activate the patient-reported outcome measure in her EHR, and she also completes a formal improvement process over 4 months to make sure that the clients that she's seeing are getting the tools, that the tools are being entered into the system, that she is getting that data and responding to that data that comes from the Promise 29. So then she logs into qpp.cms.gov, and she goes to the improvement activities, and she checks the box to attest that she did employing patient-reported outcome tools and the collection of patient-reported outcome data, which is a high priority area, and because she is a small practice, she just needs 1 high priority area for the year. She also collects and reports information on these 9 quality measures via claims. She's a small practice, so she has the claims option. So BMI, meds, pain, functional outcome, both falls measures, clinical depression, elder maltreatment, and tobacco use. So let's take a look at what her year under MIPS looks like. Again, if we're calculating quality, same slide as we saw before, but just a refresher on how the quality score is created. She downloads her data from her EHR or her registry and looks at the 9 quality measures. We're just going to take a look at the first several. First, body mass index is not high priority. She did meet the data completeness. She did have the minimum cases of 20. And then the benchmark decile, which is split up into 10 different sections, she was in the 8th decile. So she did better, as well or better than 80% of people on that measure. So she gets 8 points. Documentation of meds is a high priority measure. She does not reach data completeness on this though. Only 50% of people who could have that measure were actually measured using it. So she automatically gets 3 performance points because she's a small practice. If she was not a small practice and missed this data completeness, she would only get 1 point there. And then we look at pain. Pain is a high priority measure. She does meet data completeness. She does have at least 20 cases. And she's in the 4th decile. So she did as well or better than 40% of the people who reported that measure. So she gets 4 points for that measure. So keep in mind, she reported 9 measures, but CMS only requires 6. So CMS looks to see if she reported at least one high priority measure. Yes, she did, pain. And then CMS strikes the lowest 3 scores and only adds up the top 6 performing scores. So her performance total for quality is 31 points. She got 31 points in those measures. So if we go back to how we calculate, the first step is calculate the quality points achieved. She got 31. If you're a small practice, you get to add 6 points. She is, so she adds the 6 points. You divide by 60 because there's 60 points possible on the quality test. And then multiply by 0.85 because quality counts for 85% of your total. So in doing that, she gets 0.52. So that's the quality portion of her score. Improvement activities is a little more straightforward. She was a small practice, did one high activity, so she got all 40 points. So we're going to calculate her IA points, which is 40, divide by 40, because that's the points possible, multiply by 0.15, because it's 15% of her total, and that gives us her improvement activity amount, which is 0.15. So if we add those two together and multiply by 100, we get her total score of 67. So in this example, her total MIPS performance score is 67, which puts her in the blue category. In 2021, she is going to get a positive adjustment. It's going to be greater than 0%. She didn't quite hit that 80 points, so she's not going to get the exceptional performance bonus, but she will definitely get a bonus to all of her 2021 Medicare payments. We want to point out that if you're required to participate, but you do not, you will receive the maximum penalty. So it's very important to know if you're required to participate. If you're required to and you do not, then all of your payments in 2021 will be reduced by 7%. Again, make sure you check out qpp.cms.gov and keep an eye on AOTA.org for more information. We will be publishing more in the near future. We did want to point out that quality measures reported as a part of QPP are also included in the Physician Compare website, so definitely check that out, not only for OTs, but for all eligible clinicians. And we really, really think that this is important, and this is something that ties together all of the volume to value information and all of the work that AOTA is doing in this area, that OT practitioners must deliver high quality services that impact each client, and we know we are awesome at that. We also have to deliver high quality services that impact systems level quality measurement, and that's something that we're getting better at. We wanted to point out the Choosing Wisely campaign, which is an excellent campaign, and it's a really great step forward. If you did not listen to the Choosing Wisely presentation earlier this week, it will be available sometime next week for on demand, and we definitely encourage you to go check that out. We also included a link there to the AOTA resources. Here you can see QPP resources, which includes the QPP updates that are being published, the Year 3 fact sheet, which is a great read. You can get help directly from CMS, so we put the link there. If you're small or rural, you get even more help from CMS, but even other practices can get help directly from CMS where they can answer your questions directly. And then also let us know what we can do. Email us at quality@aota.org. Let us know what's helpful, what resources you're hunting, and what we can do to make this more successful. So with that, I will turn it over for questions and comments. And if you'll give me just a moment, I will review some of the questions that have popped up over here. And I also want to remind you that on the left-hand side, you can download the OT quality measures and you can download the slides. The first question is, did I hear it right that in 2019, the $2,010 figure increases to $2,040? I had heard it would stay the same. It is increasing to $2,040. You may have heard that it was staying the same because the difference between 2010 and 2040 is not even 1 unit of services for what most OTs bill. So it is increasing, but just barely. Is QPP for private practice therapists only? SNF or nursing facility therapists cannot participate, right? That is correct for this year, although CMS very specifically said in the final rule that they are looking at the way that practitioners in SNF and nursing facilities bill, and they are considering options for including them in the future. But for 2019, you are correct. SNF therapists are not included. The next question, what is the role of OTAs in the system? That is a fantastic question. Because of the way that private practice is billed to CMS, CMS addresses the clinician or the therapist in the rules, but that does not leave out the OTA at all. The OTA is a vital and critical part of the process, and OTAs who practice in this area should certainly be familiar with the quality measures, the ways that the quality measures are captured in the EHR, and should collaborate with the OTs to really perform the best collaborative experience for the clients possible. Is QPP to be used in SNF if providing outpatient treatment? I am going to believe that that is focused at SNFs who actually have a separate outpatient, true outpatient department and not Med B provided to long-term care residents. And really, most likely no. Unless that outpatient department is separately owned and operated and the therapist happens to work in both settings, if that's the case, then it could be included. But the vast majority of the case where the SNF actually just has a separate outpatient department that is part of the therapy group there, in general, no, it would not be included, although I would highly recommend you checking out the participation status link at qpp.cms.gov. Will Part B Medicare physician fee schedule go away for facilities too, since they cannot participate in QPP? Right now, the answer is yes. It looks like that is the case, which is why CMS is looking back at SNFs and facility-based practitioners to see how they can include them in this program. If you do not participate in the program, then the Medicare Part B payment update does still go away. For the low volume threshold, is it looked at by individual NPI or as the department or group? For example, would an outpatient department be looked at as a whole, PT, OT, and speech, in meeting the thresholds? The answer is actually both. So if you report as individual, then the low volume threshold looks at individual. If you choose to report as a group and actually do report as a group to CMS, then they will look at the low volume threshold as a group. If you want to reach out and talk through that in more detail, I'm more than happy to. It starts at the individual NPI level though, and it only goes to the group level if you actually choose to report as a group. I hope that's a little clear, but feel free to email quality@aota.org and we can talk through that in more detail. Would you suggest an entry-level therapist? Is it best to wait a year or to opt in? I think that is a great question, and I think it is up to the individual therapist to make the decision. I really think that this year is going to be the easiest year to participate. And if I'm thinking from my personal viewpoint, I think opting in 2019 is a really great idea. If you are very, very new and really have no idea what's going on, then you might want to voluntarily report. But I do think opting in is a good move. Can an OTA do improvement activities? Yes. If the OTA is a part of that practice, absolutely the OTA can do improvement activities. And in fact, CMS encourages the practice as a whole to do them as a group, and the OT can be a very vital role in those improvement activities. And if you look through them, there are some great activities that the OT and OTA can collaborate in, and that the OTA can really take leadership in some of those activities. If you're working only with kids in homes, could MIPS apply? Only if you bill Medicare. So if if some of the pediatric clients that you're seeing do have Medicare for, related to disability or some other method, then yes, MIPS could apply. If you do not bill Medicare for any of those services, then no, MIPS does not apply. Although we are seeing private practices following MIPS, private insurance and commercial insurance following MIPS very, very closely. So you may see similar issues pop up. Do small practices in low socioeconomic areas in the inner city areas double their points like rural practices? So I will actually flip back to this. There is, and I always get the acronym wrong, which is why I'm going to flip back to it. Health professional shortage areas, HPSAs. Some of those HPSAs may be in inner city areas, and if you fall into that HPSA category, then yes, you do double your points for improvement activities. There is a website where you can look and see if you are included in one of those areas or not. A small practice operates within a CCRC, providing treatment to SNF residents under Med B, as well as those we consider outpatient who live in independent homes who are also under Med B. In 2019, would this only apply to those who are outpatient? We will eventually make these changes for inpatient. Will it actually replace Med A billing where rugs are reported? I'm going to actually start backwards. No, we do not see this replacing Med A billing. In fact, Med A billing is being replaced, rugs are being replaced next year by the patient-driven payment model, or PDPM. And if you look at the member appreciation, we've done a webinar or two on that, and there will be more information coming out. So this will be for outpatient only. And then given your circumstance between the CCRC and the SNF, again, to a certain degree, that depends. And feel free to email quality@aota.org and we can talk in more detail. But a lot of it depends on how the clinic is set up and how are you billing. If you're billing through the SNF, then no, it does not apply to the SNF. But we can get into some of those details. I definitely recommend you check participation status at CMS's website. How broadly does an improvement activity need to be implemented to be considered for an IA? For example, does every patient need to participate in a depression screen in order to report the implementation of that IA? So CMS provides guidance that you should complete formal quality improvement activities. So moving from a 0% to 100% on a depression screen in that improvement activity does not necessarily have to happen. If you're at 0% now and you implement that improvement activity and you are able to increase the incidence of depression screening and you follow the more kind of detailed information that they provide, then that counts. I would say though, if you were already screening 90% of people for depression and you increase it to 91%, then maybe that isn't actually a substantial improvement activity. So it really depends on where you are now and how much improvement you make. There's not a clear cutoff, but there has to be evidence that by participating in that activity, you're providing better care or getting better outcomes. If you choose more than 6 quality measures, but for whatever reason, you do not address a quality measure, are you penalized for not addressing it? No. And the only reason you would be penalized for not addressing one of the quality measures is if you only did 5 instead of 6. But if you do 7 instead of 8, then that's perfectly fine. So you have to have reported at least 6. And reporting less than 6, you're penalized. Reporting more than 6, you're fine either way. Is this only for private practice, or will hospital-based, SNF-based outpatient programs be required to participate? CMS is looking at including hospital-based and SNF-based in the near future. How do I track this data on my own if it is not included in my EMR? Does Medicare automatically receive this data? No, Medicare does not automatically receive the data. You must submit the data to CMS, and you can do that via the methods that we talked about before. If it's not in your EMR software, there is an opportunity to partner with a registry, and that registry can help you follow and understand where you are on these tracks. And stay tuned to AOTA.org. We'll be publishing more information about what a registry might be good for and might be able to help you out with there. Hand therapy offices are included, yes, unless they're specifically part of the hospital outpatient based. Swing bed programs are not included in QPP. That was a question at this point because to my knowledge, all swing bed programs actually bill through an inpatient facility and do not bill separate therapy outpatient. So there's a question on what does one service include. We talked about the low volume threshold. You have to have 200 or more covered professional services, and CMS has, we asked for a more specific definition on that, and they went from covered service to covered professional service. So it basically means one unit that is actually covered by Medicare. So for example, if you bill hot pack, cold pack, that's typically not covered by Medicare, that would not count. But the vast majority of the units that OT bills would be considered a service, so one service, one unit. Does this pertain to home care therapy? If the home care therapy is provided, there's a couple of ways that home care therapy can be provided. If it is a private practice that bills Medicare Part B with the OT NPI, then yes, it is included. If it's part of home health or consolidated billing, then no, it is not included. Would it benefit us more to report as a group or report as an individual? And really, that depends on the practice. There are upsides to both, and it just depends on where you are as a practice. If your practice wants to compete as a whole unit with all clinicians contributing to the final score, then group makes the most sense. If each individual clinician wants to compete on their own, then individual makes more sense. And I'm happy, again, to have some more dialogue around that if you email us. Wouldn't the CCRC have to have separate provider numbers for the SNF for any outpatient services to qualify? Yes. So, yes, if the CCRC is billing through the SNF provider number, then it would not qualify for year one. That doesn't mean it's not going to qualify in the future, though. Will the PDF be available for access after the webinar is finished? Only via the webinar right now. We are going to finalize the measure list once we hear back from CMS, and once we get that finalized, then we will add that to the website. If you really want the extra PDF of the slides, then feel free to email Quality, and I'm happy to send those to you. I have a small practice. Medicare sent me a letter saying I'm exempt from MIPS, not an eligible provider type. However, my tax ID number is included in MIPS. Do I opt in as my tax ID number is included? Thanks. Again, if you don't mind, follow up individually so that we can kind of have a little more dialogue, and I'm more than happy to talk through that with you. I own a small practice in pediatrics. I'm going to say you see a date in the future that these requirements will go into effect. Not if you're not billing Medicare, although commercial insurance and Medicaid are definitely watching, so I would not be surprised if something, maybe not to the scale, but something very similar goes into effect, but no, we don't have any dates at this point. Patients admitted to a hospital and staying outpatient status for their type of admission, so observation type patients, if they're seen by an inpatient OT impact their CAT, will this go away in 2019? Short answer is yes, it will go away because there is no therapy cap in 2019. You will still have to append the KX modifier, but there is no actual cap. So the cap goes away for everyone in 2019. Do you think this will impact maintenance patients? Yes, but I don't think that much differently than it impacts the Medicare rehab patients versus Medicare maintenance patients, because the same improvement activities and the same quality measures can be applied across either of those populations. So yes, it will be impactful, but not any more than rehab. And there's just a couple of more questions. Some of them are really, really specific to individual practice. So please just email us at quality@aota.org. And I think that we are wrapping up now. So I wanted to say thank you to everyone. Thank you for joining us. I know this is a ton of information. Don't be strangers. Feel free to reach out, and we really appreciate your attention. So have a fantastic week.